welcome to another episode of Medicare Industry Insider. I'm Rachel Bremeyer.
And I'm Jalen Jackson.
And today we have a special episode that is going to go into all the major changes in the industry, from compliance to regulatory changes to policy changes to just overall in general what is going on in our industry this year. But I think the biggest thing that we need to take a look at is this is the most dramatic change year that we've probably ever seen. In at least the history of me being in this industry, but I would say potentially ever in our industry, with the massive amount of things happening. So we're going to go into a very, very long list of different things to be aware of and to be to take note on, because I think it can help impact how you go about this fourth quarter of this AEP to make sure that you retain.
Absolutely. And this is going to be a longer episode. We're going to have to keep things pretty high level because there is so much to cover, but check the show notes. Alex, our camera guy's right back here. We do have show notes, right?
It's true.
Okay, perfect. Great. Okay, so check the show notes. We'll have a bunch of links and data and all the fun stuff for you to take a look at. But like one of the big things we want to talk about is just kind of what's the Medicare landscape look like from a population standpoint. And you've probably already heard a number of times that we're kind of in peak boomer, if you want to call it that. The old adage of 10,000 people a day turning 65 is now more like 11,200. So we're getting that for another 2 or 3 years until about 2027, when we'll finally start to see that boomer era taper off and the T65 rate drop just a little bit. But over the next 3 years, there are going to be more people than ever making those retirement decisions, making those decisions of whether to stay in group or go on to Medicare or keep working or retire, and they're going to need our help. And for the folks turning 65 this year, my gosh, what a doozy of a year. There's going to be a lot going on to confuse them even more than folks have dealt with in the past.
For sure, yeah. We are going to dive into that. So let's just start. So one of the first things is just all the marketing changes that you'll have to deal with this year. So in addition to an election year, which that happen every 4 years, but usually when an election year happens, there's a lot of extra noise in the industry. So that means mail usually slows down. Usually ad space gets a little bit more expensive, a little bit more diluted if you are trying to utilize any ad space. So just being in mind and keeping that in mind, basically, that what you were saying, when are you saying it, and what is kind of conflicting with your conversations too.
And understand how it might affect your clients' perceptions of what's going on this AEP. Unfortunately, the election does overlap with annual enrollment quite a bit. So we're likely to see, just like in elections, we've got a chunk of people that always vote, Republican, a chunk of folks that always vote Democrat. And then I had a, poli-sci professor in college that called it the mushy middle, and that could go either way. And
I'm stealing
and your clients are going to be the same way. Those kind of harder line folks that they have their worldview, they don't care, they're going to vote one way or another, are the same folks that don't really care how the election goes. They're probably going to make their planned decision and not worry about it. But there are going to be a chunk of folks that have concerns that may want to wait until after the election to make a planned choice. So plan on that month of November being maybe a little busier than usual. We normally talk about a November lull, between we've got the drug plans out of the way the first couple of weeks of October, and we've gotten our early birds out of the way. And then as we get closer to Thanksgiving, things tend to slow up just a little bit. I don't think that's going to happen this year, because you're going to have all those folks that waited for the election to decide which way they want to go. Might be busier than ever, or more consistently busy all AEP this year.
So add additional wrench in your marketing plan. There's also a new regulatory, or I guess it's final rule, that is changing the way that you can purchase leads and put out leads. So it's basically one-to-one contact. So it can't be, mass marketing saying an agent is going to be reaching out to you. Obviously, there's current disclaimers that are required, but going forward, it'll be one-to-one contact. So that means that lead companies will not be able to resell aged leads, things like that. So if you are looking to buy leads, you're going to be looking to probably see maybe more expensive leads, maybe a larger amount of leads that are required.
Sure.
We're just speculating on some of the things that this could happen with, but it is going to be an interesting year in terms of, like, if you are wanting to purchase leads or put leads out, it has to be one-to-one contact. So that'd be like Rachel Bremeyer is going to be reaching out to you to talk to you about this product. So
absolutely,
it'll be interesting.
Well, and this is one where a lot of agents may have seen this scoop under the radar a little bit, just because it was from the Federal Communications Commission. So a 3-letter agency that a lot of agents don't think we really have to worry about, but they affect our daily life quite a bit. So these updates to the Telephone Consumer Protection Act, TCPA, do apply to telephonic, print, online, digital, of any type of advertising. And again, gonna look for things to be a little more campaign-based, which not only means might get more expensive, might have higher minimums, things like that, but also more lead time on those campaigns. You're not going to be able to say, I'm having a slow day, let me go buy a couple aged leads and make some phone calls. That's not going to happen anymore. Going to have to look at setting those campaigns up and really planning ahead. The other thing is this rule applies retroactively, so that any leads not generated under the new compliance guidelines also become non-compliant when this rule goes into effect in January. So if you have leads that you're sitting on right now that are, say, an aged lead that you purchased, those leads will be invalid and no longer constitute permission to contact come January. So all those old leads you've been sitting on, this is kind of that last shot to get some mail out to them, get something out to them to rekindle that relationship and regenerate that permission to contact in a compliant manner.
I think the other big thing to note on this is because the FCC is involved, it's not just CMS, which we've also said is a little toothless. And when it comes to actually managing and handling reporting and things like that, the FCC is not. They do have teeth, so you could potentially get a very large fine if you're not following the rules. So it comes back to the agent. So when you are looking at lead companies and vetting lead companies, making sure that you're doing your due diligence also. And talking to the lead company to make sure that you can see the disclaimer, what it's actually saying, who it's going out to, and that you can pull the entire line of sight of what does this lead look like for the client in case you were to get a compliance regulatory or regulation situation with the FCC. So absolutely, just making sure that you understand that it's on you, not the lead company, and that you do a lot of your own vetting.
Yep. And we'll keep moving because, like I said, we got so much to cover. But if you need a list of questions to ask a lead vendor, if you need to know what the details of this particular rule look like, of course, reach out to us. We're happy to share what we've got. We've got some questions you should ask your lead vendors and what you need to get from them. And we're happy to give that to you.
Absolutely.
But definitely some big changes to money, to cash flow for this year. So lots of changes under the final rule, or as I call it, the final rule. There are many, many, many final rules every year, but the one that most people refer to as the final rule.
He's air quoting. Are you just listening?
Yeah, if you're just listening, I'm air quoting heavily. But what we're actually talking about is the 2025 policy and technical adjustments to Medicare Advantage and Part D plans, 1867 cost plans, and PACE, I believe, is the last one. It's a heck of a little lineup. But lots of changes to commissions this year particularly. So changing the fair market value that CMS sets every year for Medicare Advantage and Part D commissions to still run their normal calculations. It goes up. It's an average of 2.5% per year, but there is no statutory requirement, minimum or maximum, that goes up. It's based on a little algorithm that CMS runs every year. They're going to run that algorithm like normal this year, and then they're going to add $100 to it. So $100 for new enrollments, $50 for renewals. So that'll be kind of a one-time jump in the fair market value. And then next year, they'll just run their normal calculations with that new number. So we can anticipate that commissions this year for a new to Medicare Advantage enrollee will be somewhere in the range of around $730. But again, don't know for sure until late July, early August. Mm-hmm. So that's kind of what we're anticipating. That $100 bump, of course, is intended to replace a lot of what used to be considered administrative fees or marketing fees, things like health assessments that we used to get paid on as agents, going away, no longer going to be allowed to be paid for health assessments, as well as a lot of other things, certain marketing costs or other administrative payments. So that $100 is supposed to replace that. And then we've also got the added complexity of non-commissionable plans.
Mm-hmm. Yeah, we'll see a lot of major changes in terms of we'll go into a lot more, I think, when we get to the IRA section about non-commissionable plans, but that'll definitely be an extra added situation. So I think in terms of an agent looking at this is you are getting paid a little bit extra for everything, but also looking at what expenses maybe you're losing. For example, also co-ops are going to be a lot more managed by carriers, so you probably will not be getting as much of that. So I wouldn't expect that this year. If you did HRAs and that was something that you supplemented your income with, think about other ways that you can make that back up. Maybe it's cross-selling, maybe it's getting additional clients, whatever that may be, but just making sure that you've actually taken a look at your bottom line, where you got your money from last year, and how all these changes that we just talked about are going to affect AEP this year.
Absolutely.
So technology, we'll pivot again. There's a lot of changes on technology. I think one of the biggest things is, and you've seen it in every industry across the board, it's a huge buzzword right now, but artificial intelligence. That AI revolution is definitely coming into play. We're seeing that everywhere, from carriers implementing it with underwriting to make sure that you're getting those underwriting answers back way faster. We actually talked to a Medicare supplement company that is looking to hire way less people for this AEP because they are leaning so heavily into the AI underwritten side, so they don't have to hire as many new underwriters for AEP. They can just, get a response back really quickly through their technology. So we're seeing things like that where claims are also being looked at. So underwriting, then we've got the claim side where carriers are using AI for claims. But you're also seeing a lot of technology implemented in a lot of the CRMs and things like that agents utilize. So if you are using the Medicare Center or Medicare for Agents CRM, the Ask Integrity button on the bottom is the artificial intelligence that you can use. It even summarizes your call recordings. You can say, hey, Ask Integrity, can you summarize Jane Smith's appointment for me? And it'll summarize your appointment. So there's a lot of really neat things that artificial intelligence is doing to work into our industry as well.
Yeah, unfortunately, it is not all raindrops on roses and whiskers on kittens. Some of my not favorite things are also happening. So obviously, we've had a lot in the news about technology in regard to things like cyber attacks. Obviously, the Change Healthcare hack early this year that caused around $22 billion in claims to not be processed for almost a month. That severely impacted cash flow for provider offices, pharmacies, many folks within the healthcare landscape, and really crippled chunks of the healthcare industry for an organization that processes a huge number of claims and payments every year. So even United Healthcare expects that breach cost them about $1.6 billion this year. But again, the outsized impact of that to providers and people that were waiting on payments is even more severe. So definitely some things to look at. Ascension Health, they detected unusual activity in early May. And then, of course, that has been a cybersecurity event that has affected millions of people as well. So we continue to see healthcare be a prime target for cybersecurity events and for hacking attacks by black hat groups around the world that see the value in that client and payment data, or simply ransomware type attacks, such as the Change Health attack, where they threatened to release that data to the public without payment. So definitely some things to be on the lookout for, making sure that in addition to your regular errors and omissions insurance, this is the insurance agent and me talking, talk to your commercial, your property and casualty agent, talk to them about your business policy, make sure that you do have some cyber liability and data breach coverage built into your agency to help protect the crazy amount of data that we store, and help cover any of those costs associated with a breach, however unintentional it might be going forward. So lots of stuff going on in
I would
the tech space.
I think that's a really good point, just to take a look at what ransomware insurance or cyber liability insurance you have as an agent. And in addition to that, I've even had agents reaching out to us saying, hey, what is this? Does it apply to me? And so I think just being aware that your clients may be getting more letters, because they are required, whatever company is affected is required to send out a letter to your client saying that their information might be jeopardized. So as an agent, he might just be getting more of those more often. So just be aware that when you see something like that, this is a sector that is getting attacked pretty heavily, our industry. The other thing that we want to bring up is just the random illnesses that used to be dead are coming back, mainly due to people not getting vaccinated. So the MMR vaccine, the measles, mumps, and
Rubella.
Rubella. Thank you. I was like, we didn't put the actual name in there. Syphilis, chlamydia, mumps, all those diseases are coming back. We've seen it random outbreaks in different states. So just be aware that like healthcare is something that's constant, and people do need to get vaccinated. And as an agent, guess what? Your clients get vaccinations for free now. So it's a part of the IRA. So just making sure that you're having conversations with your clients about their health and being aware of any major changes with that.
Well, especially as we go into AEP, maybe looking at, measures you can take in your office, looking back to like things we did during COVID. Obviously not that serious, but just you don't want a flu bug to run through your office during AEP. You don't want everyone to be catching colds, even minor things like that. So just looking and kind of re-examining, what are your wipeable surfaces? Do you have plenty of additional cleaning products as you see more traffic in the office? And, are you taking measures to keep the office tidy and arranged in a way that is going to promote that health and well-being for your staff, your clients, yourself, to make sure that you're still functioning in top condition all through AEP?
So we're going to pivot to access to care. We have a lot of bullet points that go into the access to care, but basically the gist of it as we go through all of this is that access to care is not as readily available as it used to be, and it's unfortunately not on the positive swing, like you said, the raindrops on roses side. So we're going to talk about some of our not favorite things that are probably going to continue to happen through access to care.
Absolutely. Starting with nursing homes. We've done entire episodes on skilled nursing care and on nursing home access and some of the pressures they're facing. They continue to face both price pressures for being able to hire nursing staff as well as staffing requirements set by CMS that have drastically increased. They either have to increase the number of staff they have on hand and certain types of staff, that of course is a huge cost center, or they have to reduce the number of patients they have in that facility, all without much movement on reimbursement rates for those same services. So something's got to give. Actually, if you look at some of the data out there, we may have mentioned in a previous podcast, there was a study by the American Hospital Association a couple of years ago that said that, since the pandemic, the average length of hospital stay has increased by 19%. And the number one cause, actually the number 1, 2, 3, and 4 causes were the inability to find appropriate post-acute care to be able to discharge those patients, folks that needed inpatient mental health services, inpatient rehabilitation services, other non-acute services, and we couldn't find anywhere to place them. Folks that can't go home, they do need that extra care, and there's just nowhere to send them sometimes.
In addition to that, we're also seeing small town hospital closures. So that's also a huge strain on access to care. So if you're looking at, individuals who are living in small towns, they're now looking at having to go to big hospitals and driving really far. Or if it's not closed, and they're looking at like it turning into more of a critical care type of situation. So looking at some of our data that we had done some research on, about half of the rural hospitals lost money in the past year. And we're looking at potentially 418 rural hospitals that are vulnerable to close in 2024. So it's kind of scary, just the amount of people who will lose access to care coming up in this next year.
Yeah, and I know in our rural health episode a while back, we mentioned the rural emergency hospital program, where if they would like to get some extra federal money to help manage costs, rural hospitals do have the option to enroll in, certain rural hospitals have the option to enroll in the rural emergency hospital program. The downside for your community is that pretty much strips you down to your hospital down to an ER on wheels, and they get rid of all the inpatient beds. They get rid of a lot of the outpatient services. They are an emergency room and not much else. So turning them into basically a transfer station to get them to a tertiary care center. So definitely not what's good for a lot of rural communities, and we've seen that in the unwillingness of opting into that program. Among the around 1,500 hospitals that are eligible for the rural emergency program, we've actually seen less than 24 actually opt into that program, because for most communities, it's not a good solution.
Yep.
Even if it means financial benefit for that hospital, a lot of these hospitals are choosing to better serve their communities with what they have, rather than stripping down to be just an emergency room.
Well, you can't
not help their community.
You can't have primary care visits in. You can't have, there's so many things that preventative wise they can't service their local community.
Absolutely. And what we hope to see with this next bullet point of telemedicine flexibilities, so right now those are kind of on that wind down through 2025. Very possible that we'll see more restrictions when it closes, but
just to back up, this is from COVID, was all the restrictions kind of loosened up in terms of telehealth. Now they were looking, since COVID's over, I'm also air quoting.
Yeah.
It's supposed to be winding down and closing some of those flexibilities in 2025.
Mm-hmm. Yeah, but we do have a bill on the floor right now in Congress to re-extend that, to allow high deductible health plans to not require deductible payments for telemedicine services, and to continue to allow providers to bill for telemedicine services similarly to they would for an in-person visit. So that could increase access to care, could increase revenues for some of these rural hospitals, and could help a lot of them stay afloat.
Yeah. If they do extend it, that bill would push it all the way through 2026. So we'd have 2 more years of that flexibility. So it'd be really good. We had a whole episode on mental health, and it is a huge topic, but it also is something like if the telemedicine does get cut, that's one of the biggest things that people are using telemedicine for is mental health. But mental health, we're literally in a mental health crisis right now. There was a poll done that said 90% of Americans feel that we're in a mental health crisis. 38% of people are in a mental health crisis since the onset of the pandemic. So mental health has been a huge topic in the news across the board. Looking at trying to figure out ways to, help people who are having mental health struggles has been a huge topic as well across the board. So hopefully the telemedicine continues. That allows people to continue to get the care and coverage that they need if they can't get it from their local area. And also I feel like people are a little bit more willing to pick up the phone and have a conversation opposed to go someplace if it is a mental health, because there's a lot of stigma that goes behind that.
Well, and just access to care. There are absolutely not enough providers to go around in the mental health space, especially when you look at of the 3% or so of providers that don't accept Medicare assignment, almost half of them are psychiatrists. Yep. It's just hard to get that care because of reimbursement rates and a lot of things like that. We're going to talk a little more in depth about star ratings later, but I think you'll continue to see in the Medicare space a huge trend toward mental health being a highly valued service, with the increase in weight that mental health services are getting under the star rating system. So definitely a big push towards that. And, lack of providers is an issue all across the board. And I think that leads into our next point, kind of looking at the day of the independent physician being gone. So, your hometown doctor, your solo practitioner, not tied to a large medical group or hospital. 77% of U.S. physicians are now employed by health systems, hospitals, or other businesses. 12 years ago, it was less than 30%. So huge percentage of them, over half, are now owned by non-physicians. So a lot of reasons behind this. Some of it is just the administrative burden of becoming a doctor nowadays, between your malpractice and your administrative costs with your electronic health record systems, and the cost of doing business and having to run a business and be a business. I know that your dad experienced that firsthand, Rachel.
Malpractice and all the technology that you have to implement as a doctor, and all the claims things. There's so many things now that it's so expensive to run your own practice. So a lot of them are just choosing to work with a hospital now.
Yep. And there's a huge financial incentive as well. So you've heard us talk in past episodes probably several times. And if you ever listen to me anywhere, you've heard me talk about something called site-neutral payments. So a talking point for NABIP and a lot of other organizations for several years now. One of the big reasons for a hospital group or a medical group to acquire an independent physician is they can pretty much overnight increase bottom line revenue by about 30% because of these facility fees that they can charge as a hospital-owned entity. So there's a pretty strong financial incentive for hospital groups to buy out these physicians, bump up revenue, and unfortunately add to beneficiary costs right along with that.
It's an advantage to a physician in terms of all the shared services that they're going to help take care of, but gives them a little less leeway in terms of how they run their practice. And then also, like you just said, a lot of extra expenses for the client. The next thing we want to go into, because we have a lot of agents in the senior market who also do a lot of business under 65, is the limited short-term plans, changing from where they used to be 2-year plans going down to a 3-month plan. There is an extra month that they can roll into, flexibility basically. But the other caveat is you cannot put them in the same plan in the next 12 months. So if you have, for example, a United Healthcare plan that you put them in for the first 3 months plus a 1 month rollover, then you can't put them back in that United Healthcare plan to renew it. You have to pick a different carrier, a different plan. So it's causing a lot of strain on these agents going, okay, what options do we have after September 1st?
Yeah. So definitely a lot of changes in that market, just, with looking at folks that maybe just needed to fill a gap between employment and Medicare, COBRA and Medicare, didn't want to cover the high premiums on an ACA plan because of their income, something like that. Maybe they don't have any pre-existing conditions. There are a lot of cases where a plan like this does make sense, but we can see where there's a lot of pressure to shorten those plans back down to truly be a short-term option for folks. So expect to see a lot more enrollment in the ACA, which of course has been a policy priority for the administration for several years now, as folks get pushed off of those short-term plans or having to hop a lot more. So those clients are going to be a little more labor-intensive than they used to be going forward.
So say if you're an agent in the senior market, sorry, I sound like I don't know what's going on. If you're an agent in the senior market, you've got this additional strain of AEP coming up with, oh my gosh, how am I going to take care of all my clients, to also dealing with, what are we doing with all these short-term plans, clients you've got to take care of before September 1st, or else they're going to start having those 3 months windows.
Absolutely.
So you'll go into Medicare supplement changes now, because there are also a lot of supplement changes, one of them being close to double-digit rate increases across the board with Medicare supplement plans. Historically, when you look at claims loss ratio, carriers are looking at around an 80% claims loss ratio. During COVID, they saw a significant decrease to low 70s, 74-ish. They thought it was going to go back up to 80 and then kind of maybe a little bit higher once people went back to the doctor. Maybe you got some unresolved cancer or whatever preventative service that they weren't actually getting taken care of during COVID. So they were expecting a little bit higher claims loss ratios, but then they were hoping that it would level back off to 80%. That's not happening. We're looking at an 84%, almost 84% across the board market loss ratio. So carriers are trying to mitigate that and fix where they're losing. So we're going to see a lot of double-digit increases coming up.
Well, and these are nationwide averages. We've seen and heard from carriers and seen the data that, there are some states where the average carrier is running closer to 95% loss ratios or even over 100%. But rates have been stagnant for many, many years. If you look at, say, a turning 65 Plan G rate today compared to 2014, 10 years ago, they are shockingly similar, within a margin of error similar. Nothing else in our life has stayed that consistent for that long. So there's a lot of kind of artificial deflation of prices as we've tried to keep things stable for folks. And the long-term cost of that has been, as Medicare reimbursement rates continue to slow down, but medical inflation continues to rise, that 20% that a med sup carrier is on the hook for hasn't changed from a percentage basis, but that percentage has resulted in larger and larger dollar amount claims. So lots of things going on in the med sub market from a just premium pressure standpoint, but we're also seeing some things like, anti-discrimination changes from HHS. So looking at the cost pressures that will put on carriers, as it is likely that they will start offering under 65 med sups in all states, as opposed to about the 20 states that offer some form of under 65 med sup. So continuing to see those discrimination changes that could affect premiums and rates going forward, and then the kind of letter plan shift that's currently going on, trending a little bit more towards Plan N and away from Plan G, and then of course Plan F falling off pretty drastically as we escape that era of folks that are aging in and eligible for Plan F.
So yeah, we just kind of recapped a ton of stuff with Medicare supplements. We'll dive into IRA next, and that affects a lot more with Medicare Advantage and Part D. So we'll go into a lot of the changes and updates with that. So the IRA is not new. We had a whole episode on the IRA. I think it was one of our early episodes, actually. IRA is responsible for the $35 insulin. It's responsible for the free vaccinations. Well, 2025, the new thing that's coming up that's going to make a dramatic wave in our industry is the $2,000 max out of pocket for Part D. So one of the big things that we can see with that is basically carriers are now trying to figure out how to mitigate that. So historically with drug plans, you've got the manufacturer and the clients who would put the most weight into paying for those prescriptions. Going forward, the carrier, after that $2,000, is now going to be responsible for the rest of that. So they're trying to figure out, how do we handle that unknown expense and what are we doing about that? So we'll dive into that just a little bit.
Yeah, absolutely. A lot of changes to that cost sharing responsibility. You know, the numbers that I've heard is, you know, if you look at right now today, your average Part D plan is on the hook for 11% of total expenditures for the year between co-pays, premiums, Medicare subsidies, manufacturer discounts, things like that, PBM discounts, clawbacks, all that great stuff. Next year, that is anticipated to be 29%. So solid 250% increase, almost 300% increase in their cost outlay on a beneficiary basis. And with this $2,000 cap, what we know today or in the years past is we can tell you about 10% of beneficiaries would make it up to the donut hole, the coverage gap on a Part D plan, and only around 4% of folks would hit the catastrophic phase. We have no clue how many people are going to hit this $2,000 max out of pocket, but it would not shock me if it was over 40%.
Yeah.
Just looking at how many of your clients spend that $2,000 a year right now compared to the $8,100 that it currently takes to get into the catastrophic phase this year. So likely to see a lot more people hitting that max. It's going to affect not only the folks that are currently in Part D, but folks that are making decisions about retirement, as we see, not for 2025. We've been granted a little bit of a grace period by CMS, but as we go into 2026 and they start changing the determination of what is creditable coverage under this new Part D program, we may actually see some group plans no longer be creditable coverage for Medicare. So those folks working past 65 are going to have some tough choices to make.
Yeah, 2026 is going to be another big year then, especially if you're working on the under 65 group market, or if you've got networking partners for that, just to make sure people are not going to end up with a Part D penalty going forward. So we'll talk through Part D first, because there's a lot of things that both Part D and Medicare Advantage can and can't do to help mitigate some of those losses. Part D, your drug plans are going to have a lot less levers to pull to get that back. So we'll see, and this is just us speculating, obviously, of some things we can see carriers potentially doing, but because they're going to be responsible for that, there's less things they can do to mitigate that loss. So things like premiums, they could increase premiums, they can change tier ratings, they can drop formularies, they can drop networks. There's a lot of different things that Part Ds can do, but less than what Medicare Advantage can do.
Absolutely. I really anticipate, I think pretty universally folks anticipate premium increases. Carriers have said that. Lots of, talking heads out in public have said that, including these two talking heads.
Yep.
But, premiums are going to increase in most cases. Or there's also the possibility that rather than simply increasing premiums, carriers could choose to completely redesign their Part D plans and kind of start from scratch, either by crosswalking folks to a new plan or just truly starting from scratch with a new plan.
Yeah.
So that's also a possibility. We'll know more as we get closer to AEP, but I could definitely see a strong possibility of that as well.
We could also see commissions potentially being cut of, maybe their idea is this plan we're probably not going to make money on, so we're just going to cut commissions from the agent. We could also see the Part D plans taking a look at, potentially pulling, which we've already seen a couple carriers do that. So there's a lot of options that Part D can do, but I would say across the board, if you have clients who have a Part D plan, they need to have a meeting with you.
Absolutely.
We're looking at historically 10 to 15% shop and switch during fourth quarter. We're seeing everything that we've been talking to with a lot of the different research companies have been around 40 to 70% shopping and switching this year. So making sure that with everything being up in the air, we don't know what's going to happen with this. So just getting your clients in front of you.
Yep. And I think that'll be even more important as we start to see what these carriers are going to do going into AEP. And again, this is going to be probably the latest we have ever gotten that information. I really wouldn't anticipate being able to trust much of what we hear until about mid to late August if not September.
Right.
Because of the rebid process and everything else that will be going on around that time. We're anticipating a lot of late in the game changes leading up to AEP, especially on the Medicare Advantage side, where they do have a lot more of those levers to pull. And I think the big thing we've gotten spoiled with the past few years, and I mentioned this to a group of agents yesterday, is, we've seen a lot of plan parity. Not universally, but in a lot of strong markets, you have a lot of plans that look really, really similar. And, networks and things being the same, you kind of get to pick which logo you like, and that's all the choices the client really needs to make. But that's not going to be the case. Everyone is going to have to decide, but meaning carriers, Medicare Advantage organizations, they're going to have to decide which benefits they feel bring the most value to their beneficiaries and their enrollees. And they're going to have to decide which things to raise, to lower, to get rid of, to add, as they look to make up that cost outlay that they're seeing on the Part D side, while still meeting the total beneficiary cost threshold that they're allowed to raise and lower benefits by.
So with Medicare Advantage, we'll see, like Jalen said too, the levers and the different changes that they can do. They have a lot of extra benefits that they can play with. They may try and keep their $0 premiums. They may try to keep some of the selling points. We've seen some carriers already coming out saying they are going to keep their Part B give back, which is something that initially everyone was thinking they probably cut. So they may try to hang on to whatever that selling point was. But there's a lot of extra things that they can play with, like the over-the-counter benefits, dental, vision, hearing. They may change, if you go to a hospital, how many days you have to pay out of pocket and how much that is. There's a lot of little things that they can play.
Pocket dental benefits. I would say if you look at what are the most likely levers, and this is total pure speculation, which I love to do more than anything. But if you just look at what are the most likely levers, the max out of pocket is something that a lot of people haven't really cared much about the past few years because it is so unlikely for folks to hit that. It's kind of like the catastrophic phase on drug plans. It's an incredibly small number of folks who hit that max out of pocket. And in a lot of markets, not all, but in a lot of markets, we've been really spoiled with really low max out of pockets compared to the statutory maximum. So, those $2,500, $3,000, even, $4,500 max out of pockets are pretty low compared to the statutory maximums, which will be, I believe, as high as $9,000 next year. So
yeah, we'll see.
I think that's a really easy lever for carriers to pull because it will affect such a small percentage of beneficiaries. I also think, dental has gotten incredibly rich over the past few years. That'll be another lever that's pretty easy to pull. And then a lot of the kind of out there extras, some of the healthy food cards, some of the, especially SSBCI and VBID benefits, some of those qualified benefits, between these cost pressures and pressures from CMS to prove that things like pest control and air conditioners and utility benefits are actually valuable to improving health and well-being. A lot of pressure from CMS to just, if you want to offer that, that's fine, but you have to prove that there's value in it. I think those are going to be some of the easiest benefits for certain carriers to cut. And then, of course, like we've already said, things like network design, expect a lot more aggressive negotiation from carriers this year as they try to mitigate those costs on all sides of the book, not just in benefit design. And then, looking at how those plans work too, I would expect more to come out of the client's pocket early. So maybe even a return to some plans that have medical deductibles. We've seen some carriers have pretty successful plans that had a medical deductible in the past few years. So that's another possibility. But,
so I would say, as an agent looking at all of this, there's a couple of things I think Jalen hit on the head with. They filed their plans June 3rd.
Yep.
They're, with all the changes going on in the industry, they're refiling, they're rebidding everything. So in the past, we've been able to look at star ratings and sneak peeks and benefits and seeing all this stuff early in the game, and you can kind of plan out your fourth quarter. I don't think you can do that this year. The sneak peeks are going to be almost useless. They'll probably come up with really high level stuff, which we've seen one carrier so far just have really high level things, no benefits, nothing extra in there, because they don't want to put something out that's not going to exist in a couple months. So making sure that you are getting contracted and certified with every single carrier that is available in your network area, because they don't mean anything this year with all the rebids and everything. In addition to that, we talked about commissions too, some of them being non-commissionable. That's not a possibility. That's not out of the realm of possibilities. And then also service area reductions. We may see carriers, I think Taylor mentioned it before.
Some have very publicly said that that's what they plan to do is reduce benefits and service areas.
So a lot of big changes. One thing that we haven't touched on yet was the smoothing provision. That is something that is also built into this of trying to help mitigate some of the $2,000 cost, because of course now the client is responsible for that. So if you have a $2,000 drug, what do you do with that? So what they built in was a provision where basically a client can opt in. The pharmacy would help them sign up for that particular drug, and it would smooth out the $2,000 cost or however much the drug cost throughout the 12 months or whatever month they started, so that they're paying over time. Well, here's the catch: is that
there's a lot of catches.
There's a lot.
One. It's a messy deal.
It is. The process has not been outlined yet, so. As of right now, it looks like the pharmacy enrolls them. The pharmacy then bills, or lets the carrier know. The carrier then bills the client, and then the carrier has, I think, 90 days?
60
days to get back to the pharmacy with their expenses. If the client chooses not to pay, they do not get dropped from their plan, and they cannot be denied for their medications. But they are going to rack up some pretty hefty medical debt. And
they can be disenrolled from the smoothing provision, or what you'll probably see more often is the Medicare Prescription Payment Program, or M3P. They can be dropped out of the program. So if they miss 2 payments in a row, the carrier can drop them out of that program. So
the program, not the plan.
Not the plan, but out of the payment program. So they would still owe those missed payment amounts for the drugs they had already picked up. But if to fill any future prescriptions, they would have to go back to just paying at the pharmacy counter. But, at the end of the day, this was designed for, grandma gets cancer and she's on a $15,000 a month oral chemo pill, and she's going to hit $2,000 max out of pocket in January. Now that beneficiary doesn't have to come up with $2,000 all at once. They can pay $167.67 every month all throughout the year, and maybe be able to afford to live and spend time with their family, which is just crazy. But it is going to be quite a mess as we start seeing that implementation. The big complexity here is any beneficiary can enroll in this program. It does not make sense for every beneficiary to enroll in this program. And CMS really sees it as agents, carriers, and pharmacists' job to educate folks on not only when they're eligible, if they're eligible, but how to handle this program. So expect to get questions, expect to see information from carriers. There are provisions that if someone does have a single medication over $600, the pharmacy is required to notify them of this program. So you will probably get a lot of mid-year questions. It is a more important year than ever that if you do have pharmacy networking partners, this is the year to get in front of them and let them know what they're in for, because pharmacies can't really turn away this business. So even though it does mean that they're going to have to cash flow this a little bit for the carriers, as the carriers may take their time paying, it's going to be part of their plan contract. If they want to be in network with that plan, they're going to have to take all business from that plan. They can't, discriminate from folks because they're a part of the prescription payment program.
Yeah, so that'll be a fun situation. But yeah, I think as an agent looking at it, knowing about this one and working with the pharmacies that you currently network with, just to make sure that they're aware of it, that they're prepared for it, and that you can help them with that. And I think it's an opportunity for an agent to potentially network with pharmacies they didn't have partnerships with in the past. So we may see a lot of pharmacies, like you said, cutting networks because they don't want to use a particular carrier because they know that they're not paying the provision back as quickly as they would like, or I don't know, it'll definitely cause a lot of strain on especially the mom and pop pharmacies.
Sure.
So let's roll into a common misconception for Part D, as in dog, as in drug premiums. There's been a common misconception that 6% base beneficiary cap affects that premium, and that's not the case.
No. So the National Base Beneficiary Premium serves 3 primary purposes. It does not necessarily affect the actual plan premiums that a carrier can charge to consumers. We've seen that year after year, and it's not true. Carriers can still charge whatever they deem appropriate within the confines of the Part D program and how their plans are designed. But the national base beneficiary premium does a few main things. One, it does serve as a baseline for Part D benefits for that Part D basic benefit, meaning it checks all of the literal, legal, technical boxes to be considered a Part D creditable plan. It kind of puts a baseline on what CMS expects to reimburse for that basic benefit plan. Most plans offer some kind of supplemental benefit, whether that's reduced cost sharing at any tier level, reduced deductible exposure, anything like that can push them into supplemental benefits and allow them to charge those higher premiums. The other thing that the base beneficiary premium does is it affects late enrollment penalties. 1% of the national base beneficiary premium per month that someone went without creditable coverage. And lastly, it is part of the calculation that is used to determine which Part D plans are eligible for full subsidy under the low-income subsidy program. That's really all the base beneficiary premium does. It doesn't, to an extent, does not majorly affect the premiums a carrier can actually charge for a drug plan, which is why there's a drug plan available in like 2 counties in Massachusetts that's $198 a month.
Yep. Yeah, and it is not out of the question to see $0 plans have way more than, you obviously can't calculate a 6% increase, way more than 6%. We were even hearing things like a $35 drug plan go up to $120 plus or minus $15. So it is not out of the question for a drug plan to cost as much or around as much as a Medicare supplement this year.
Yes.
So having conversations with your clients about that and the why behind picking a drug plan is important. You're an agent. Insurance is to protect them in case there's risk. They will probably be using their drug plan, so making sure that they understand the why behind paying for their drug plan and keeping their drug plan, especially so they don't get that Part D penalty going forward. If they choose to pick it back up, if they happen to get cancer, they're not at risk. And then also alternatives like a Medicare Advantage plan if they really can't afford that cost. So there's a lot of directions, but just know that 6% does not apply to the premiums for Part D.
Not to the actual plan premiums. And a lot of this is pressured. So all of these changes, this is kind of what we've been, it's a perfect storm, right? So most transformational year that our industry has ever seen, potentially ever, definitely in the past decade, probably in the past 20 years. But there's a lot of pressures on plans. So not just all of this Inflation Reduction Act stuff, not just the policy and technical changes for 2025, but also star ratings. Star ratings are causing some big changes as CMS has phased in some new adjustment models and changed which star ratings metrics are weighted more heavily. We're seeing for the past couple of years a general downtrend in star ratings and expect to potentially see that for another couple of years while carriers adjust to some of these new metrics like improving mental health and several others that have been given a higher weight rating in the star ratings metrics than in years past. But as they navigate those changes, we're also on the other side seeing some successful lawsuits against CMS. So a couple of carriers did recently sue CMS over improperly assigned star ratings. Both of those lawsuits have been at least partially successful and will result in potentially billions of dollars in quality bonus payments to those carriers. And due to those two favorable rulings for those plaintiffs, CMS is actually reviewing all star ratings for 2024 now, and they're expected to reissue those star ratings sometime in the near future. So because of this, we can actually see potentially a pretty drastic change in the 2024 plan year star ratings that could drastically affect reimbursement to any given carrier. So while any carrier's individual plan might receive a higher or lower star rating under this revision, generally it's expected that this will raise star ratings as a whole. So could be a lot more expense by CMS to pay those quality bonuses, could also give carriers a little more money to play with right before AEP in a year where they are going to need to do more marketing than ever before.
Yeah, we're seeing rebids happening right now. We're seeing, all of the changes that they're trying to disseminate and understand. And now we've got this wrench thrown in of star ratings being completely overhauled for the first time ever that I've seen in the middle of the year for this plan year. I think I'd ask you like, wait, 2024, we're reading this right? 2020, this is this year. So that is going to affect their income, what they have to play with in terms of money. And there's a lot of things you as an agent can do to help affect those star ratings, especially now that the health assessments are going away. That was something that was helping their star ratings. So just they're probably going to still collect that data and utilize it somehow. So we'll see that going forward. But star ratings are a big deal. Keeping an eye on it is important.
Absolutely.
Medicaid changes are another big thing that we'll roll into. One of the biggest things, and I feel like this has kind of slid under the radar, and people haven't been bringing up as much as I think they should, especially if people are working in the dual market. But the dual SNP election is changing next year. Drastically. It'll look closer to like a 5-star election where instead of having that quarterly election, if there's a plan available that has been both approved by the state and the federal government, then they can enroll with this like 5-star type election.
And this is kind of a multi-step process. So we've got CMS putting out in the policy and technical changes that they want to and are removing that quarterly election for maintaining dual status. It does not affect elections for change in status or for gaining or losing Medicaid. It's just that maintaining dual status quarterly election. They're dropping the LIS only election periods to apply to PDP only, standalone drug plans only, and it will be a continuous monthly election. But this new quarterly or ongoing election, like Rachel mentioned, kind of like the 5-star plan, is only for integrated dual plans. So those carriers that have both a state Medicaid contract as well as a qualifying D-SNP plan that integrates care between the two entities. So those are currently only available in about 20 states. So as carriers catch up to this and as states decide whether or not to adopt an integrated care model, in many states, 30 of them right now, beneficiaries are going to have AEP and OEP just like anybody else, and those quarterly elections are going away. So that could be really good for agents. D-SNP market has been one that we've seen a lot of agents have success with. I think a lot of people have maybe at least a partially false assumption that D-SNP plans switch a lot more often and they're hard to keep on the books. This is going to make it a lot more easy to keep those folks on the books by removing that election period from a lot of them. So it could be a really good opportunity. If you've never been in the D-SNP market before, this AEP would be the one to get into it because that's going to have the same stability as the rest of your book going forward.
And I will say if you have a large book of D-SNP clients or referral partners, it's going to drastically limit your options of changing those people and getting them into a plan. In addition, a lot of people get, their Medicaid status and their Medicare status, everything prior to turning 65. So a lot of times when they age in or by the time you've gotten them, they already have it. So the maintaining side is where you're going to be struggling with supporting them. So you'll be looking at other alternative elections. There are some 5-star dual plans. If they continue to stay 5-star, that's an option.
Yep.
Or if you are in other elections like OEP or AEP, that's an election option as well. But you'll be looking at other alternatives for the maintaining status going forward. And that isn't to say that it's not even more confusing because we're still in the Medicaid unwinding. A lot of states have been paused with that, but that's not to say a lot of people are still trying to get corrected if they were disenrolled and maybe they shouldn't have been disenrolled. And in addition to that, it's now you're going into another year coming up where they're going to be reevaluating who is actually eligible for dual status. So there's just a lot up in the air of who actually has it, should they have had it, were they dropped unintentionally? And then now we're adding this additional election on top of it.
Well, and we've got some really interesting stats. If you look at it nationwide, of the folks who lost Medicaid in the past year or so, 47% of them got Medicaid back. They either didn't fill out the paperwork correctly, couldn't be reached because, Medicaid had an old address, something like that. 28% of them picked it up through employers, maybe folks that got Medicaid during the pandemic because of the job loss, but then became reemployed and couldn't get off of it, even if they wanted to, because of the pandemic provisions. And then we've got 23% of folks on Medicaid that still don't have coverage. Now, the largest chunk of these beneficiaries are in the under 65 and even children. So folks who lost CHIP or lost underage Medicaid due strictly to income levels. But there are a chunk of those that are dual eligibles that may be looking for help. And right now, especially those uninsured, are taking a huge toll on community health centers, hospitals around the country that, they kind of have to go back to using the ER like their primary care doctor because that's the only option they feel like they have. So now we're going to roll right into talking a little bit about some, again, non-CMS-based changes, some things with Federal Trade Communication or Federal Trade Commission and Department of Labor, some big changes this year coming to just how your business might operate, things that might affect the way you do business, starting with a new rule on non-compete clauses. So starting in July, what the rule is going to do is ban all new non-competes after the implementation date for all workers and nullify any existing non-competes for non-executive workers. So it is going to keep in place existing non-competes for senior executives. It also does not prohibit any non-competes relating to the bona fide sale of a business, and it's not going to prevent other business protection measures such as requirements to maintain business confidentiality of trade secrets or confidential information and things like non-solicitation clauses. So that's a big change in an industry where 2-year non-competes were kind of the norm, regardless of how enforceable they were in your particular jurisdiction.
Yeah, so as an agency owner, this is something definitely to watch. It is part of the FTC, so there's information we can send if this is something that applies to you. But for time's sake, we'll keep rolling.
And I will say, most of these last couple things we're going to talk about, there is pending litigation on this, whether or not FTC has the ability to do this, who all it applies to, things like that. But by and large, plan on non-competes no longer being valid, especially not for any senior executives going forward, any new senior executives going forward.
So the next thing that Chandler had kind of touched on, but it's income-based changes. This is across every industry. Everyone's getting affected by this. But if you are an agency owner and you have anyone who works for you, basically effective July 1st, so both of these are going to affect July 1st, salary thresholds will increase to the equivalent of an annual salary of $43,888. And then it increases again in January 1st on 2025 to $58,656. So basically you're looking at, do you want to keep people on salary? Is it worth them to go on hourly? And then if it is hourly, then you're looking at overtime pay. So just making sure that you've taken a look at that.
And the big thing I want people to take away from this is that if you've got, say, an admin person who's on salary right now today for $35,000 a year, you can keep them on salary, but they will no longer be exempt from the overtime requirements. So you're just going to have to take that $35,000, work it out to an hourly amount, and you will be required to pay them overtime depending on your state's particular overtime rules. Here in Missouri, it's anything over 40 hours per week. Some states, it can be as stringent as anything over 8 hours per day. None of us ever work longer than 8-hour days during AEP, and it does not matter if it's, we take off Fridays during the summer to compensate for that. It doesn't matter. In most states, it's on a weekly basis, anything over 48 hours. Some states may be a little more strict. Check your local labor laws for how they...
Check state, too, because some states it's based on a weekly 40 hours and some it's based on an 8-hour day.
Yes.
So double check your state for sure, but we just want to make sure that you were aware of the income-based changes across the board, round 1 starting July 1st, round 2 January 1st.
Absolutely. So big changes. It's the first time that number has jumped in several years, and it is going to phase in an every 3-year inflation-based adjustment. So that's going to be a big change to folks that have administrative staff, anyone who's not on a commission-only basis. And a reminder that only applies to guaranteed salary amounts. It doesn't apply to bonuses.
Correct. So I think to wrap everything up, there was a lot of changes we threw out. This was a very long episode. We wanted to make sure that you were aware of everything going on. Not everything. We did a lot of high level, and we cut a couple things. But the gist of it is there's a lot of opportunity. Whenever there is change, that equals opportunity. There is a lot of people turning 65 this year that need your help, that need hand-holding through all of the changes that they will also see in terms of premium, in terms of networks, in terms of how things are, what access to care they have. There's tons of stuff across the board that they really, really need you. We had a deft episode a couple episodes ago, but we did mention that 87% of people consider an agent something that is valuable and that they need in terms of making decisions. And they also want to utilize agents. So like as an agent, knowing what's going on, preparing yourself for fourth quarter, and just being overall a resource for people when they are floundering, trying to find a valuable person to help them through this decision. In fact, most people view this as the most important financial decision that they will ever make. So being available for them and being prepared to meet with every single client this year is going to be so, so important.
Yep. 45 to 70%. I know you've heard that number before, but that's the percentage of people that we anticipate making a plan change this year. That means as many as 45 million seniors will be out there looking for help this year. Seniors and other Medicare beneficiaries looking for help making the right plan choice for them. If there has ever been a year to get into the business, to grow your business, to take that leap of faith by hiring another agent, hiring an admin so you can expand your business, I think this is the year to do it, because we've never seen a time where we knew for a fact that people were going to be making changes at this scale. And that change, if you can get in front of people, if you can create the bandwidth to help more people, there will be folks looking for it. And if you're an agent, if you're working with us, if you're working with other people, this is going to be the best chance you've had to double your business over the course of the 8 weeks of this AEP that we've ever seen.
Mm-hmm. I think the biggest thing for agents is focus on 4 big things. It's going to be figure out your marketing now. We've talked about that at the very beginning of this episode. Figure out your technology now, streamlining your systems and processes, figuring out how you can lump your clients together so you can see as many people as possible. But every single one of your clients are going to need a touch point. And if you can figure out those little gaps, like you said, in your schedule to gain more clients, that's even better. And then, of course, make sure that you are contracted and certified with every carrier available, because we don't know what's going to happen this year. So just be
not
prepared.
sure who's going to be the most competitive.
So it's going to be a dramatic shift this year in our industry. We've talked through a lot of different things that are affecting our industry. We just hope this helps you out so that you're prepared for everything coming up this AEP. And with that, we'll go ahead and wrap up this episode. So thank you so much for watching Medicare Industry Insider, and we'll catch you next time.